Good evening, good afternoon. I'll be talking briefly about the globus pharyngeus and try to incorporate the important things. Coming to the globus pharyngeus, this condition is characterized by non-painful sensation of lump in the throat in the absence of dysphagia and odynophagia. It was described more than 2000 years ago by Hippocrates, Dr. John Purcell in 1707 described it elaborately, and later on in 1968 the term globus pharyngeus was coined and was changed from globus hystericus, which was called earlier. It has slight female preponderance. The most recently and appropriately it is defined as persistent or intermittent sensation of lump or foreign body in the throat for at least 12 weeks. The sensation should be there between meals. No dysphagia or odynophagia should be there, and there should be absence of pathological GRD, achalasia or other motility disorder. In USA, there are 4% ENT referrals of globus pharyngeus. In my practice, at least it is 8 to 10%. It is long-lasting, recurrent, and it impairs quality of life. The most important cause of globus pharyngeus is GOK. This is God only knows. It is poorly understood. Many theories are there. Important theories are the GRD, but 24-hour ambulatory pH gave conflicting results. Cricopharyngeal spasm, esophageal motility disorder, H. pylori, lingual tonsillar hypertrophy, cervical osteophyte, iron deficiency anemia, TM joint dysfunction, thyroid pathology, anything, everything you can think of may be the cause of globus pharyngeus, but exact GOK. It is multifactorial. Investigation, workup, and treatment differs from institution to institution. And the main aim to diagnose or to rule out is to rule out upper aerodigestive tract malignancy. But majority of studies have failed to show any link between upper tract aerodigestive tract malignancy and the filling of globus. So how to proceed? Coming to the history. Rule out any history of dysphagia, odynophagia, respiratory distress, any severe allergy or symptoms suggestive of postnasal drip, any recent onset, obvious hoarseness, any hemoptysis, hematemesis. There is a scale known as Glasgow-Edinburgh throat scale, which has 10 points about the discomfort, pain in throat and all those things. Basically, this scale is for assessing and monitoring the severity of some common throat ailments. So, while you start treating the globus pharyngeus patient, you can use this scale in between to show the improvement of symptoms on the patients. Clinical examination, of course, complete head, neck, oral cavity and nasal examination to look for any thyroid swelling, any neck mass, any severe allergic symptoms, any asthma. Coming to the investigation, 90-degree laryngoscopy, a must investigation to rule out any mass, any osteophyte, any lingual tonsillar hypertrophy. Nasal endoscopy, of course, to rule out allergy and postnasal drip, like a short clip of this diffuse DISH patient, diffuse interstitial skeletal hypertrophy. These patients can have dysphagia, globus sensations like in CA vallicula patient. They don't have dysphagia, they only many times come with some globus sensation. So you have to do 90-degree laryngoscopy in each and every patient along with the 0-degree nasal endoscopy. Sometimes UGI endoscopy can be done, or you have to refer for your GI colleagues if the symptoms are persistent, if any dysphagia or odynophagia, severe GRD is there. Investigation not required is the barium swallow because it is not dynamic and the visualization is very poor. Many a times for the persistent symptoms of globus, I use video fluoroscopy. I do many to screen, use as a screening method at my OPD to rule out any obvious feeling defects, any motility disorder. It saves time for the patient and it is cheaper than getting done UGI endoscopy. Although UGI endoscopy has its indications, I'll be skipping these videos of video fluoroscopy. I have already shown them. Coming to the treatment, the exact cause is not fully understood, so exact treatment it is difficult to determine, but still drugs that are already mentioned in English literature are the GRD treatment, the double dose of PPI for at least 6 to 12 weeks. Even low dose of amitriptyline. Low dose of amitriptyline. Minimum dose available is 10 milligram. I start with 5 milligram. Most of these globus patients are the female patients. They sleep by 10 p.m. or 11 p.m. and they have to get up at 5 a.m. to cook for their children and for their husbands. So you can't use full dose of amitriptyline. I start with 5 milligram in these patients and ask them to take at 7 p.m. so that the time they have amitriptyline has effect, the sedation part or the sedation comes, the female must be already going to the bed. Mechanism of action of TCA. It potentiates and prolongs activity of serotonergic and adrenergic neuron, and it has some neuromodulator effect on brain axis, and it betters sleep pattern. Side effect. The dose normally of TCA used by neurologists is at least 25 to 50 milligram, and I am giving 1/10 of the dose. So most of these side effects are not seen when I am using 5 or 10 milligram. But of course the side effects are like anticholinergic side effects, the sedation, sometimes weight gain, sometimes some dysphoric agitation, fine tremors, seizure threshold lowered, and postural hypotension, some sexual distress and rashes and jaundice, rarely but not with the doses I am using. Interaction, it potentiates sympathomimetic drugs and alcohol, antihistaminics, some interaction with phenytoin, carbamazepine, SSRIs and all MAO inhibitors, but it is not the dose which I am using or we ENT people are using. Now onwards, I am telling about the drug I am using for globus pharyngeus treatment since 2012 when I started my clinic. Haloperidol and risperidone. I use haloperidol and risperidone if symptoms are very troublesome, or rather say now I am using in every of globus pharyngeus patient. And of course when the tests come out normal. Haloperidol is typical antipsychotic. It has high potency, no weight gain, less epileptogenic, and jaundice etc. are very rare. It is preferred drug for acute relief. Risperidone, it is D2 and serotonin receptor blocker along with alpha blocker. It has less extrapyramidal side effect and less epileptogenic. It can causes agitation, weight gain. Overall side effects of both antipsychotics. These antipsychotics, the doses used by psychiatrists or even sometimes by neurologists is minimum 5 milligram. The safety margin of the Serenase or haloperidol up to 20 to 30 milligram is used. Risperidone minimum they use is 4 to 5 milligram and use 5-10 milligram. I am using 0.25 to 0.5 milligram and I am getting my results. Overall side effect of both antipsychotics are of course CNS, some drowsiness is there, but usually tolerance develop. Some weight gains, it is seen with risperidone, not with haloperidol. Some aggravation of seizures, sometimes some palpitation, postural hypotension, anticholinergic side effect like dry mouth, blurring of vision. Hyperprolactinemia due to D2 blockage may cause galacturia and gynecomastia, some elevation of blood sugar, triglyceride. Sometimes extrapyramidal side effect like Parkinsonism, rabbit syndrome in which perioral tremors are there, acute muscular dystonia. These effects come when you use for prolonged time of more than 5 milligram. I am using 0.25 to 0.5 milligram for few months. So rarely in thousands and thousands of cases of these patients, I have seen 2 or 3 of these side effects. Only galacturia and one male patient complained about some sexual disturbances. Otherwise, I never came across any of these extrapyramidal and all those things or the side effects in the doses I am using. Sometimes akathisia, malignant neural syndrome, tardive dyskinesia, all those things. Hypersensitivity reaction, they are rare like cholestatic jaundice, skin rashes and all those things. There may have some interactions of antipsychotic with other CNS depression with levodopa. but the dosage which I am using, I never came across any specific side effect. Coming to the third drug I am using is skeletal muscle relaxant. Two types of skeletal muscle relaxant is there. One is the centrally acting and one is the peripherally acting. We are dealing with the centrally acting like baclofen or tolperisone. Peripherally acting are generally used by general anesthetics. Baclofen is GABA agonist. It reduces the release of excitatory neurotransmitter, and by this it causes skeletal muscle relaxant. Its half-life is short, so the usual doses I use is 5 milligram tablet twice or thrice. It is used in post-stroke spasticity, but on higher doses, say 20-25 milligram BD TDS. I am using 5 milligram BD because I will be later explaining in 2-3 slides. Specific precautions, sometimes we should take precaution or reduce the dose in renal and hepatic dysfunction. In pregnancy, it is category C. Breastfeeding, we need some precautions. Side effects, only sedation and some muscle weakness. The dose I am using, no muscle weakness I have come across. Sometimes hypotension, peripheral edema. We should avoid sudden withdrawal. Tolperisone, it is also centrally acting muscle relaxant, but it is more well tolerated. The doses I use is 100 milligram BD. So coming to last few slides, my journey with globus pharyngitis. I started my practice in Jan 2012 at Patna, Bihar, India. On seeing patient with complaint of something is there in my throat, something pricking occurs in my throat, I feel suffocated due to my throat problems. I went to literature and came to know, oh, it is globus pharyngitis. I started using PPI morning and evening, means that omeprazole and all the pantoprazole. Hardly 10 to 15% patients had symptomatic relief. Then I started using amitriptyline, 10 milligram half tablet for 10 days, then 10 milligram HS. My results were from 10% to 25 to 30%, means 1/3 of patients were out of complaint or symptomatically better. I discussed this problem with my psychiatrist friend. He suggested me using haloperidol at low doses. I started using 0.25, then 0.5 milligram, and the results jumped to 80 to 85%. I later on switched to risperidone for better safety profile. Coming to the side effects of the drug, in my practice, only 2 female patients till now have complained about the milk ejection or say galactorrhea. Only 1 male patient have complained about the sexual disturbance. For last 1 to 2 years or in between 1 to 2 years, in the patient, in spite of giving these drugs, if they have continuous symptoms, I used to send them for UGI endoscopy, and invariably 90% of those patients, they were H. pylori positive being done on HP kit. So after seeing so many of patients in my globus pharyngeal treatment failure patient who were being diagnosed as H. pylori positive also, empirically I started giving H. pylori treatment for 2 weeks, the triple drug and 4 drug combination, and results were even better. Later in my practice, I started realizing that these globus pharyngeal patients are 2 types. One having only irritative symptoms in the throat like pricking symptoms and some heaviness in the throat, and some are having obstructive symptoms, means on difficulty in swallowing even the saliva, or someone is pressing their neck, this type of obstructive symptoms. So my treatment protocol right now is in mild symptoms of globus pharyngeus, I use PPI with risperidone. In moderate to severe symptoms of globus pharyngeus, I also give H. pylori eradication kit for 2 weeks along with the PPI treatment and risperidone 0.5 milligram with low doses of baclofen. I have already mentioned 5 milligram or 5 milligram BD or tolperisone if obstructive symptoms are present. Only irritative, then risperidone and all those things if severe symptoms with HP kit. But if obstructive symptoms, this something is constricting and I'm suffocating, then I use baclofen or tolperisone. After a few months, I gradually decrease the doses, although I get 20 to 30% of recurrence of symptoms, but many a times these patients have recurrence many months after the drugs all the drugs have stopped. I am seeing more than 7 to 8 patients of globus pharyngeus in my OPD daily, both new and follow-up, many times more than this, and this is my experience of 12 years of treating thousands of patients of globus pharyngeus. Thank you, Jai Hind.
Have you come across the topics trial that's just been published? There's just a randomised control trial, and they randomised patients with throat symptoms, what they call persistent throat symptoms. One group were randomised to proton pump inhibitors, and one group were randomised to a placebo, sham treatment. And what they found is that the sham patients did better than the electrical ones. So your thinking on the PPI front is correct. I guess what I would just ask is, again, just sort of reflecting on yesterday, and these are the sorts of people that we referred to me to be seeing therapy. Would you ever have speech therapists at all? Obviously, it would probably be unsustainable to have every globus patient sent to speech therapy, but certainly some of the throat symptoms, what we would call throat symptoms, we would certainly have a go at treating them with therapy. But it's very interesting, your approach. I'm very interested in your talk, so thank you. It's great.
Sir, I am Dr. Dilmat Talukdar. Thank you, sir, for your last presentation. I have a question for Dr. Rishi, sir. Dr. Rishi, sir, what is the duration of treatment for globus pharyngeus?
At least continuously for 3 months.
All the risperidone, haloperidol 3 months.
Either risperidone or haloperidol with PPI for 3 months. Sure. This HPK treatment is only persistent symptoms and severe symptoms. Treatment is 2 weeks only. The three drug combination, the amoxicillin and clarithromycin with the double dose of PPI.
So, did you use Parkinil with haloperidol?
The doses I think that is you are talking about trihexyphenidyl. Actually, the doses I am using, I never came across any patient with having extrapyramidal side effect. So I never, one male patient with sexual disturbance and only 2 female patients with galacturia.
So no need to use this.
I never needed to use.
Okay, thank you, sir.
Good question.
Haloperidol and risperidone, antipsychotic drug.
Yes, sir.
I have written this antipsychotic drug. Patient will go to the pharmacy. They will tell you, "Are you a psychic patient?
It is the
Why doctors have prescribed this? Do you have any evidence or document for supporting this practice?"
Sir, just a step before, amitriptyline is being given to this patient. So they are not depressed patients, they are not manic patient, they are not migraine patient. Now coming to practical approach of me, I used to write the treatment is globus pharyngeus and ask them to go and read that. On reading them, they come to know that anxiety is there and depression is there and all those things there. So they don't question me that why I have written this antipsychotic drugs. Because I already write the things, even if they are not so learned or Google, they don't do Google. I ask them to get it Googled by their relatives. So relatives will be saying that it is associated with anxiety, it is associated with depression, it is associated, and amitriptyline, all those drugs, even SSRIs are given. So they don't usually question.
Thank you.
Thank you, sir, for your nice presentation. So my question is for Rishi, sir. Sir, which drug do you prefer more, amitriptyline or risperidone or
Amitriptyline I have stopped. It has so many of side effects, and my results don't increase. With PPI, I give risperidone. It is better tolerated and not much of side effects are there. But if a patient wants quick within 1 week, then you can start with haloperidol. Haloperidol is more potent than risperidone, but risperidone has less side effect.
Thank you.
Hello. If cervical osteophyte is the cause of globus spilling, then what will you do?
Globus is the sensation, nothing. Nothing. You have to tell the patient that it has nothing to do with these things, and you just write the drugs. Because if you start impressing the patient that this is the cause of globus, then they will never going to attain global free, global free symptom or become symptom free, because they know that you have done nothing for this complete, the permanent bony structure.
I would probably do a video fluoroscopy as a biofeedback technique with people, because I often find that if it can be frustrating for people that nothing's done, because the surgery is pretty unpleasant to deal with those sorts of things. If you can avoid ACDF surgery and all that, that's a good thing. But what I would say is that sometimes just biofeedback and knowing that food is passing through it and it's not causing harm. They may well have marked osteophytes that may be impinging, but I think sometimes just knowing that it's not flow limiting can make a real difference to how people feel about things. So, not for everyone, but I'd recommend it for biofeedback personally.
No, we will take a few questions, but few of our respected chairpersons just have a bit of commitment, so we'll take a photo.
It can be very helpful for people.
Thank you.
Yes, question.